Welcome to my channel. In previous video, I covered about acute tonsillitis and chronic tonsillitis. Now I am going to discuss about the facial diphtheria. The most common area for facial diphtheria is tonsillitis. Before we are enter into the proper topic, we are going to see about the objectives of the facial diphtheria or etiology and clinical features and complication and how to treat the facial diphtheria. First, etiology. Why facial diphtheria is occur? It is due to gram-positive bacilli, that is Corynebacterium diphtheriae. It spreads by droplet infection. The incubation period is 2 to 6 days. Some people are carriers of the disease. They don't have any symptoms, but they have the gram-positive bacilli in their bodies and they spread through the droplet infection to others. They harbor organism in their throat but have no symptoms. And clinical features. Children are more affected because they are a low immune system. Oropharynx is most commonly involved and the larynx and nasal cavity also affected. In oropharynx, the grayish white membrane forms over the tonsil and spreads to soft palate and posterior pharyngeal wall. The grayish white membrane is seen in facial diphtheria over the tonsil and it also can spread through the full oral cavity. Maybe it's in soft palate, hard palate or posterior pharyngeal wall. It is quite tenacious and causes bleeding when we try to remove. The lymph node, that is jugular lymph node, is enlarged and tender, sometimes presenting a bull neck appearance due to enlargement of the jugular digastric lymph node. The patient is looked like toxemic, but fever seldom rises above 30 degrees Celsius. The patient is mainly looks like toxic. What are the complications if we can't treat or we forget to treat the facial diphtheria? It produces exotoxin. It is toxic to heart and nerves. So it causes myocarditis, cardiac arrhythmia and acute circulatory failure. It is all heart related symptoms. And neurological complications appear a few weeks after the infection and include paralysis of soft palate, diaphragm and ocular muscles. In larynx, diphthetic membrane may cause airway obstruction. The grayish white membrane extends up to larynx. It obstructs the airway. How to treat? What is the treatment of facial diphtheria? The treatment is started on clinical suspicious without waiting for culture report. If we see the white grayish membrane over the soft palate or posterior pharyngeal wall or tonsil, we don't wait for culture report. We start immediately antibiotic. They aim to neutralize the free exotoxin in blood, still circulating in the blood, and kill the organism producing the exotoxin. So, antitoxin is the dose of the antitoxin is based on the site involved and duration of the severity of the disease. It is 2000 to 40,000 units of diphtheria in less than 48 hours. If it is less than 48 hours, we started 20,000 to 40,000 units antitoxin, or when the membrane is confined to the tonsil only. And 80,000 to 1,02,000 units if disease has lasted longer than 48 hours, if it is less than 48 hours, if it is more than 48 hours, or membrane is more extensive. Antitoxin is given by IV infusion in saline, about 16 minutes. And then sensitivity test by conjunctival or intracutaneous test with diluted antitoxin is adrenaline. Some patients can't tolerate the antitoxin, so that's why we have to perform sensitivity test to that patient. Then only we avoid the allergic reaction. So in sensitivity test, we are give conjunctival or intracutaneous antitoxin with adrenaline. Antibiotics is used by benzyl penicillin 600 mg for 7 days. If it is allergic to the patient or contraindication to that patient, we are go for erythromycin, that is macrolides. Thank you.